Hi, I'm Truck, a former social worker.
And I'm Janine, a former case manager. We are currently psychiatric nurses, but we remember what it's like to work in community mental health without a background in neurobiology or pharmacology.
Our goal is to help case managers and social workers better understand what their clients are experiencing so that they feel competent and confident that they can meet the needs of their community mental health clients.
This module discusses the neurobiology and treatment of psychosis with a focus on schizophrenia, a chronic psychotic disorder. Before we begin, we believe that you'll have the best learning experience by downloading the guided note sheet and following along with this presentation. The link to download this is just below. Let's get started.
Psychosis is a state that occurs when an individual has lost contact with or has disturbed perception of reality. In this state, individuals typically experience delusions, hallucinations, or a breakdown in their speech or behaviors. Psychosis is a key feature of schizophrenia, but it's also seen in severe depression and mania, in substance use disorders such as methamphetamine abuse, and in severe medical conditions.
Schizophrenia, which is typically chronic and disabling, involves multiple areas of impairment, including positive, negative, and cognitive symptoms. Positive symptoms are the most obvious and intrusive and include the typical symptoms of psychosis previously discussed. Negative symptoms, on the other hand, are often less apparent but can be quite disabling and include decreased verbal communication, loss of motivation and interest in interacting with others, and reduced emotional expressiveness. The most disabling symptoms of schizophrenia are the cognitive symptoms, which include problems with attention, verbal skills, memory, multitasking, and planning and organization.
But before going further, we'd like to acknowledge that neurobiology is only one of the many explanations for psychosis and schizophrenia. As a matter of fact, some social and environmental determinants like maternal stress, someone's culture, or living in the city are actually found to be more predictive of psychotic disorders than the explanation that neurobiology can provide at this point in time.
Psychosis, from a neurobiology point of view, is believed to be the result of abnormality in both brain structure and function. The prefrontal cortex, also known as the PFC, is located just behind the forehead and is an area that is highly responsible for many higher thinking tasks such as motor planning, organization, and regulating impulse control. So where am I going with this? You really just need to know that a working PFC provides a cohesive experience of reality, and any problem with this area can lead to a number of issues, including symptoms of psychosis such as delusions, hallucinations, paranoia, as well as negative symptoms, or behavioral symptoms such as lack of volition and aggression.
One theory that we wanted to talk about is the dopamine theory. Dopamine, as you know from popular culture, is a quote-unquote feel-good neurotransmitter that acts in the reward system of the brain. But dopamine has an equally important role in hormonal regulation, movement, and thinking. Again, dysfunction with this system will lead to any number of problems, one of which is psychosis. Current research also suggests that other neurotransmitters in the brain, particularly glutamate and GABA, which can affect the ways in which dopamine works, may also contribute to psychosis and other mental illnesses. Nonetheless, the dopamine theory is arguably the most popular, if not convincing, as most antipsychotic meds available today operates under this hypothesis.
Another theory that has shown some promise in early research that you may hear more about in the future is the neuron cell death theory, also known as apoptosis. As we grow up, our brain takes in tons of information, building connections in the brain. As we get older, we get rid of the connections that aren't as useful. This is called pruning. This theory basically says that psychosis is a result of over-pruning, which leads to significantly decreased neuron connections and a smaller brain size.
In terms of medication for psychosis, all of the current medication we use work by blocking dopamine and falls into two categories: first-generation antipsychotics, or FGAs, and second-generation antipsychotics, SGAs.
FGAs are also known as typical antipsychotics or neuroleptics, and they were the first drugs created for the treatment of psychosis and include drugs such as Thorazine and Haldol. Although they primarily work by blocking dopamine, they're also considered, quote, dirty because they affect many other systems in the brain and body, often producing some really ugly side effects. They are most effective for treating the positive symptoms of schizophrenia, but unfortunately, they can worsen negative and cognitive symptoms and can cause motor problems and abnormal changes in the body's hormone system.
Second-generation antipsychotics, or atypicals, on the other hand, are a relatively newer class of drugs. In addition to blocking dopamine, they also act on serotonin. There is something very interesting about this combination, as the interactions between these two seems to result in significantly less neuromotor and hormonal problems. Some drugs in this class can be helpful for negative symptoms as well.
FGAs and SGAs start working in a few days, although their beneficial effect on agitation can be seen within hours. As a general rule, the full antipsychotic effect is usually seen in 4 to 6 weeks. FGAs such as Thorazine and Haldol are much more likely to cause side effects known as EPS, or extrapyramidal symptoms, as well as TD, or tardive dyskinesia, as compared to SGAs such as Risperdal and Seroquel.
Extrapyramidal symptoms falls into 3 categories of symptoms that are often quite distressing. Parkinsonian-type symptoms such as tremors, stiffness, and shuffling gait, akathisia, a very uncomfortable form of restlessness throughout the body, and dystonia, a prolonged, distressing, often painful muscle spasm, which more often occurs at the beginning of treatment and can be very life-threatening. These symptoms are almost always worse at a higher dose and can occur in second generations but are less common at therapeutic doses.
If the patient uses antipsychotics for an extended period of time, one of the long-term side effects can be TD, or tardive dyskinesia, which is the presence of random involuntary movements of the muscles or any of the other parts of the body, including the face, tongue, arms, legs, or hands. Examples of TD include facial grimacing, lip smacking, and blinking, which you may see in patients who have been on first-generation antipsychotics for long periods of time.
Because EPS and TD is far less common in second-generation antipsychotics, they are much more frequently prescribed. That being said, SGAs are not without problematic long-term side effects of their own, one of which is known as metabolic side effects. These side effects can include weight gain, increased blood sugar and cholesterol, which can put patients at a high risk for diabetes and heart disease. Fortunately, the newer SGAs such as Abilify and Latuda are much less likely to have these problems.
The decision to start and maintain a patient on a type of antipsychotic is a highly individualized conversation that is discussed on an ongoing basis because each antipsychotic affects each patient very differently in terms of how well they work and how tolerable they are to the patient. As much as we'd like to believe, there is no wonder drug or cocktail for all cases.
And how tolerable are these antipsychotic medications anyways? Well, if it's any indication, studies have shown that for every 4 patients started on an antipsychotic, only 1 of them will still continue to take it 18 months later. Unfortunately though, without the drugs, most patients will get sick again roughly 1 year after their first psychotic break, and just about all of them will be sick again after 2 years. The reality is, psychotic disorders are a deadly and progressive disease that reduces the lifespan on average by 15 years. 5% of those affected will go on to achieving complete suicide, and many more will die from cardiovascular illnesses and cancer.
Also, you'll notice that the drugs and dosage used in the community are really different than those used in acute care, because the focus of treatment in the community is maintenance, prevention, and psychosocial rehab, which is not surprisingly very similar to your goals as case managers and therapists.
It may seem bleak, but that's why our goal as an interdisciplinary team is to change all of that for all patients. As a case manager, you have an important role in advising prescriber promptly of any adverse effect that you may notice or that your client reports to you during your visits, and of your clinical expertise in helping them managing their concerns and educating them on their choice to stop taking the meds and encouraging them on how to maintain a healthy lifestyle to counteract the unpleasant effects of these very powerful drugs.
Thank you for watching our module on psychosis and schizophrenia, created as part of a Masters of Nursing scholarly project through Seattle University. Please check out our other modules on anxiety, ADHD, bipolar disorder, and depression. Thank you.